So, good afternoon. First, I will present all members of the jury. So, Maria Lestesma Carballo, professeur Université Polytechnique de Madrid. Stéphane Cotin, directeur de recherche INREA. Sous moi-même, professeur à l'Université de Rouen. Mathieu Chabana, maître de conférence, Université Grenoble-Alpes. Et puis Jean-Louis Dylan-Secker, deux supervisors, Jean-Louis Dylan, et puis Yuan Payon. And also we have one invited member, Simon Rosé, technicien hospitalier CHU de Rennes. So, Pablo Alvarez, you can present your work. You have about 15 minutes.
Okay, thank you for the introduction. Good afternoon, members of the jury. Good afternoon, everyone. My name is Pablo Alvarez, and today I will present my thesis work, which is entitled Lung Deformation Estimation using a hybrid image-based, biomechanics-based approach for the localization of pulmonary nodules during video-assisted thoracoscopic surgery. This work was carried out under the supervision of Jean-Louis Dylan-Secker from the Université de Rennes 1, and Yuan Payon and Mathieu Chabanas from the Université Grenoble Alpes, and in collaboration with Simon Rosé, cardiothoracic surgeon at the Rennes University Hospital, and Michael Miga, director of the biomedical modeling laboratory at Vanderbilt University, where I participated in a mobility program. Lung cancer is the leading cause of cancer-related death. Each year, it is responsible for more than 11% of all new cancer cases and 18% of all new cancer deaths. It is a very aggressive cancer with an average 5-year survival rate around 19%, killing more people than prostate, liver, and breast cancers combined. However, the survival probability of patients strongly depends on the stage of the cancer at the moment of diagnosis. For instance, early stage cancers are very localized that allow for curative treatment options and significantly improve the survival probability of patients. For this reason, lung cancer screening programs aim at the detection of the cancer before the onset of symptoms. This is a low-dose CT image that is typically used for lung cancer screening. The objective is to find abnormalities in the lung tissue that are called pulmonary nodules that may be at the origin of cancer. However, these nodules may or may not be cancerous, and only an accurate diagnosis may allow for an effective treatment, both of which are generally required the resection of the nodule from the lung. Video-assisted thoracoscopic surgery is the surgical tool that is becoming the standard for the resection of the nodules. It is replacing the open thoracotomy approach with a more minimally invasive approach that allows for better and faster patient recovery. The VATS approach consists in opening ports between the ribs in order to get access to the internal structures in the thoracic cavity. The surgeon uses a camera to visualize the interior of the cavity and specialized surgical tools to manipulate the lung as required. This is an example of a nodule that is being resected from the lung using this surgical technique. The current clinical practice uses preoperative CT images for the planning of the surgery. In these images, the position of the lung nodule to be removed is clearly known. However, during surgery, as soon as the surgical ports are opened, the lung starts to deflate into itself, as we can observe in this intraoperative endoscopic view. This process is called a pneumothorax, and it creates space between the surface of the lung and the surface of the thoracic cavity wall. This space is used for the surgeon to remove the nodule from the lung, but the problem is that this pneumothorax also induces very large lung deformation that hinders the localization of pulmonary nodules. Especially, it is important to take into account that it's difficult to perform a mental mapping between the position of the nodule before the surgery and the position of the nodule during the surgery with the lung in such a deformed state. Although the surgeon may try to localize the lung nodule using palpation techniques, this approach is very unreliable, especially for small and low-density nodules. This problem is addressed in current clinical practice using various pulmonary nodule localization techniques. Most of these techniques are based on marker placement near the nodule before its resection. Examples of these markers are hook wires, dyes, or microcoils. The placement of these markers necessitates an adjuvant intervention that can be performed either preoperatively or intraoperatively, and that has some associated complications and failure rates. For this reason, researchers have proposed to replace the use of markers with markerless intraoperative imaging techniques, for which the two most notable examples are the intraoperative ultrasound and the near-infrared imaging. These techniques have already proven useful in some clinical studies, but are not widely used because they are still under development and face some technical difficulties. It is in this context that a new markerless pulmonary nodule localization technique based on intraoperative cone beam CT acquisition has been proposed at the Rennes University Hospital. We can observe in the video as a cone beam CT acquisition with the patient ready for surgery. The images from these acquisitions are used to localize the nodule during surgery after pneumothorax, as we can observe in this example. This localization is then used within augmented fluoroscopic guidance that allows the surgeon to identify the position of the nodule during surgery. This approach has also been tested in 2 clinical studies with very promising results. However, it is not devoid of limitations. The first limitation concerns the ground glass opacity nodules, which are nodules with very low density, since these ones are not visible under the cone beam CT image. The reason for this is the CBCT image has a lower quality in comparison with the CT image, and also that after pneumothorax, the lung density increases because of lung deflation, which in turn decreases the contrast between the intensity of the nodule and the surrounding tissue. The second limitation deals with the radiation exposure to fluoroscopy that not only affects the patient, but also the surgical team, as the surgical team needs to remain close to the operating table during the localization procedure. The ideal would be then to avoid the use of fluoroscopic guidance whatsoever. This brings me to the motivation of this thesis work that starts by acknowledging the fact that preoperative CT images can be used to obtain the information of the position of the lung nodule and the main lung structures, but this information in the intraoperative CBCT images is probably not known. We know that there is deformation going between the state of the lung before surgery and during surgery, but there must be a transformation that allows to bring the information from the preoperative setting into the intraoperative setting, specifically the position of the lung nodule. The objective of this thesis was to propose a methodology to account for lung deformation during VATS in order to estimate the intraoperative position of pulmonary nodules. This presentation is divided in 4 parts: the clinical context and motivation that I just presented, the understanding of lung deformation that presents an analysis of the deformation during surgery that I will present now. But first, I will introduce some of the challenges of the intraoperative CBCT data that we have available. First of all, the image quality of these images is reduced with respect to the preoperative CT images because we use lower dose in the acquisitions. Also because the reconstruction algorithms are different than those from the CT images, these CBCT images suffer from more image artifacts, such as duplication and copying artifacts. In addition, there is the field of view of the CBCT images is reduced, is limited, and the size of this field of view is generally smaller than the typical size of a human lung. As we can see in this example, in the CBCT images, there is only partial lung information, where the apex and the diaphragm are both missing. And finally, there are complex deformation patterns arising after pneumothorax. For instance, we have atelectasis, which is total airway collapse. And we also have lobe sliding. In addition to these challenges, the image before surgery and during surgery are acquired with the patient in different positions. Supine position for the CT image and lateral decubitus position for the CBCT image. The deformation between these two images, that is to say the deformation during VATS, can then be understood as two physical processes that involves the change of pose of the patient followed by the pneumothorax. In order to better understand these deformations and to facilitate their compensation, we then have introduced an additional image with the lung in an inflated state during surgery before pneumothorax and the patient in lateral decubitus position. This allowed us to isolate the estimation and analysis of the change of pose deformation and the pneumothorax deformation. And this facilitates the computation or the calculation of the transformation that allows to bring the preoperative information into the intraoperative setting by computing two transformations, one for the change of pose and one for the pneumothorax. I will present now an analysis of these deformations, starting with the change of pose. The change of pose deformation was estimated using intensity-based image registration, where a parametric transformation model is used to represent the deformation, and the parameters of this model are calculated using classical techniques in image registration. We first perform a rigid registration process with the objective of canceling all rigid body motion between the preoperative CT and the intraoperative CBCT. We use the spine of the patient as the structure for this registration, and we can observe here that there is a significant difference in the field of view of the cone beam CT image and the CT image. After rigid registration, we perform elastic registration to estimate the local deformation. We used a masking process in order to take into account the sliding between the lung and the thoracic cage, which is also very typical in lung literature. And we use the freeform deformation transformation model for the representation of the change of pose deformation. For both of these registration processes, we use multi-resolution approach and a normalized cross-correlation similarity metric that was used for the computation of the cost function. These registration processes were implemented using Elastic's toolbox. The registration was performed in a data set with 6 clinical VATS cases. In the change of pose, we are focused in these two images that correspond to the preoperative CT and the intraoperative CBCT of the inflated lung. For the validation of registration, we placed paired anatomical landmarks in bifurcations of vessels and airways. The landmarks across clinical patients varied according to the visibility of the CBCT images. And this is an illustration of the spatial distribution of the landmarks for one clinical case. We use target registration error for the validation of this registration, which is the Euclidean distance between the transformed point in the transformed landmark from one image and the landmark from the other image. These are the distributions of target registration errors for both rigid and elastic registration across clinical cases. And we were able to obtain average target registration errors in a range between 1 millimeter and 2.8 millimeters after elastic registration for all cases, which we consider accurate for the purpose of analyzing the deformation of the change of pose. Once we have estimated this transformation, we were interested in measuring the deformation between the two lung states, for which we use the definition of the deformation gradient tensor that can be decomposed into a rotation part and a stretch part. For this stretch part, it represents the variations in deformation at each point. We were interested then in computing the amount of movement, whether the deformation was isotropic or anisotropic And we used the anisotropic deformation index proposed by Amelon and colleagues, where the eigenvalues of the right stretch tensor can be used in order to quantify any deviation.
Excusez-moi, mais j'ai plus d'audio.
Moi non plus, je pense que
J'entends plus,
Ouais.
moi non plus, j'entends plus rien.
On n'a plus rien du tout. Ouais.
This upward movement indicates an upward movement of the diaphragm towards the apex. With respect to the average displacement that we observed, we acquired values between 7.1 and 23.2 millimeters across clinical cases, which is significant. And these values are very close to those reported in the long registration literature for breathing. Regarding the anisotropic deformation index, we observed that there are higher values near the lung fissures without the interfaces separating the lung lobes. This is an indication of sliding movement between the lobes, and this behavior has also been published in the lung literature for breathing deformation. And finally, the Jacobian of Deformation, which measures the local volume changes, we observed that there were highly localized hotspots that they were placed near the sliding interfaces and then are associated to registration errors. However, in the regions that we obtain good registration errors, lower registration errors, we still observed locally heterogeneous volume changes, and these changes were varying across clinical cases. We have performed an intensity-based image registration deformation estimation for the change of pose deformation during VATS that we validated using target registration errors. We found just in this analysis of the change of pose deformation that it was very large, with large displacements, anisotropic deformation near the lobe interfaces indicating that there is lobe sliding, and also locally heterogeneous volume changes and across clinical cases. I will present now the analysis of pneumothorax deformation. For this analysis, we use the same clinical data set with the exception of one case that was so deformed after pneumothorax that we could not place any anatomical landmarks. This analysis is focused in these two images. We wanted to use the same analytical tools that we use for the change of pose deformation estimation, and some preliminary results using the registration approach proved to be, for the pneumothorax to be very challenging using image registration. And for this reason, I will present the analysis based on landmark displacements only. When we observe these displacements, we can see that first of all, they go in the direction of lung deflation, which was expected, but there is a significant movement towards the apex, indicating again for this pneumothorax deformation that there is a movement, upward movement of the diaphragm. The average displacements were ranging between 24.6 millimeters to 37.7 millimeters, which is significantly higher than the displacement that we found for the change of pose. To conclude this section, we have presented a lung deformation characterization study that is a contribution in itself, given that similar studies for breathing deformation have been proposed, but none exists for VATS. We found that there is very large deformation during VATS, both for the change of pose and the pneumothorax. And when we try to explain this deformation, we first observed that there is differences in inflation of the lung volume, which corresponds mainly to the pneumothorax, a difference in gravity since the patient is changing positions, but we also observed that there is a significant movement towards the apex of the diaphragm. It has to be noted that during surgery, the patient is administered with the muscle relaxants, and since the diaphragm is relaxed, the gravity effect on the abdominal organs make these organs to push the diaphragm upwards. Hence, this explains the observations that we acquired from the images. We also decompose the deformation of the VATS as a change of pose deformation and a pneumothorax deformation that facilitated the analysis. And we used intensity-based image registration for estimating the severe deformation, for which the change of pose was possible and limited to the field of view of the CBCT image, but this was very challenging for the pneumothorax. I will now present the approach that we propose for the compensation of lung deformation during VATS. A review of the literature reveals very few works in the context of VATS deformation compensation, where authors have proposed acquisitions before and after pneumothorax on animals, CT acquisitions on humans, and there is only one group using CBCT acquisitions during surgery with the open thoracotomy approach. Since there are very few works on the VATS context, we were also interested in the breathing context, for which 4D-CT images or inspiratory expiratory breath hold images are typically used. Regarding the methods, in the VATS context, the authors have proposed surface-based methods that do not take into account the interior of the lung, a combination of surface-based methods and intensity-based registration, and also the simulation of surface pressure with hyperelastic biomechanical models. It has to be noted, however, that none of these methods takes into account the change of pose deformation that we already found to be very large, and also that most of them use a higher quality images. With respect to the breathing context, methods can be classified into intensity-based image registration, for which the Empire 10 Grand Challenge collects the state-of-the-art on breathing deformation compensation, biomechanical modeling approaches where authors have tried to simulate the lung behavior using various elasticity models and proelasticity models. And finally, since intensity-based approaches are limited to the quality of the available images, and the biomechanical modeling approaches may struggle with the uncertainties in the model parameters and boundary conditions, authors have proposed the use of hybrid methods that combine the two approaches in a complementary fashion. With this picture in mind, I will now introduce the proposed framework. This framework is based upon various strong methodological choices. The first is the decomposition of the deformation into change of pose and pneumothorax, as I already explained in the previous section. We propose to use a hybrid image-based, biomechanics-based registration approach. This is to take into account the challenges of the intraoperative CBCT images, for which the image-based part uses a free-form deformation transformation model, as I explained in the previous section. And for the biomechanics-based part, we chose to model the lung as a single structure. Now we are aware of the significance of modeling low sliding during VATS, but we wanted to evaluate the feasibility of our registration framework, and this is the reason we use this simplification. It should be noted also that there is no study in lung deformation literature modeling the multiple lobes. And finally, the biomechanical model that we chose represents the deformation that we observed during VATS. And in order to justify this choice, I will present the process of pneumothorax. This is a representation of the lung at the end of expiration. The space between the chest wall and the visceral pleura is called the pleural space. And the pressure at this pleural space is always negative in normal conditions, which translates into a positive pressure at the surface of the lung. the forces acting on the lung are the gravity, the alveoli were recoiled that pulled the lung inwards, and thanks to the negative pressure at the pleural cavity, the chest outward recoil pulled the lung outwards. During pneumothorax, after the rupture in the parietal pleura, there is a disruption in the pressure at the pleural cavity that results in the chest outward recoil not affecting the surface of the lung anymore, which is then only affected by the gravity and the alveoli inward recoil. The alveoli inward recoil are forces at the surface of alveoli that during pneumothorax collapse these alveoli, pushing the air out of the lung. Given the importance of airflow in modeling pneumothorax, we have chosen to use a Proelastic model of the lung that allows to a macroscopic representation of air parenchyma interaction. The Proelastic model uses the assumption of two coexisting domains, a solid domain that in our case is lung parenchyma, and a fluid domain that in our case is the air. This is very much like a sponge with pores and fluid flowing through the pores of the sponge. The hypothesis is that the stress on the total porous medium is partially carried out by the solid domain and partially carried out by the fluid domain. This is known as the principle of effective stress. Each one of these domains has a constitutive law. In the case of the fluid domain, this is Darcy's law that relates the instantaneous flow rate with the pressure drop. And the solid domain is assumed to be elastic. Under conservation of momentum and mass, the total stresses at the interior of the porous medium should add to 0, and the fluid flow must be conserved. These are the classical static Proelastic equations proposed by Biot, but we have used an alternative version of these equations proposed by Miga and colleagues, where an additional term is used in the conservation of mass equation that allows for the representation of fluid evacuation. The hypothesis used in this model is that the principal source of deformation during pneumothorax is then the fluid domain, and for this reason we have used a linearly elastic law to represent the solid domain. This model was implemented using GetFEM framework, which is an open source tool for the finite element analysis. With these methodological choices, we propose then to compute a patient-specific biomechanical model using preparative information and to decompose the intraoperative deformation into two phases. The first phase to compensate for the change of pose deformation, and the second phase for the pneumothorax deformation. At the end of the second phase, we will have the estimation of the nodule position during surgery. I will now present in more detail each one of these processes. Regarding the extraction of lung geometry in the preoperative CT image, we perform semi-automatic segmentations using chest imaging platform, an open source tool. And we then created finally a finite element mesh with linear tetrahedral elements. And I recall that the model that you use for the lung is a single structure. For the phase 1 that accounts for the change of pose deformation, this is an hybrid approach where the image part is based on the registration process that I presented in the previous section. Starting from image segmentations of the lung, we perform rigid registration using the spine, and freeform deformation transformation represents the local deformation. I recall that this deformation field is defined only within the field of view of the CBCT image that does not contain the complete lung anatomy. And this is the reason that we simulated using an elastic model the change of pose of the lung for the whole anatomy. Now we assume that during change of pose, there were no airflow, for which we only considered the solid domain, and we used a linearly elastic biomechanical model. The displacements that we computed using image registration were applied as boundary conditions to this simulation. And since most of the displacements were known, the influence of material properties in the final solution is very low. And this simulation was performed in order to estimate the complete long geometry after long change of pose deformation. That we can see here, this as extrapolation that was obtained using the finite element method. And this is important because this geometry was required for the simulation of pneumothorax. Now, regarding the phase 2 that accounts for the pneumothorax deformation, first of all, we identified that after rigid registration of intraoperative CBCT images, there was still some deformation at the level of the hilum. And in order to take into account this deformation, we perform intensity-based registration based on a coarse segmentation of the airways. In addition, we extracted points at the surface of the deflated lung in order to construct and reconstruct the lung surface that was used for the guidance of our model. As for the boundary conditions, in the solid domain, we applied imposed displacements at the airway inlet that were computed from the deformation field representing hilum deformation. And we used frictionless contacts with the thoracic cavity and the diaphragm. The diaphragm was allowed to move upwards as we observed this behavior in our analysis. And finally, we took into account the effects of gravity. And for the fluid domain, we applied homogeneous transmural pressure at the lung surface, and we activated the air evacuation term that allows to create pressure gradients that shrink the lung, as observed in pneumothorax. As for the model parameters, we know that they are patient and intervention dependent, but no study has been proposed reporting values for the lung during pneumothorax. In addition, in the breathing context, various authors have proposed heterogeneous material properties. For this reason, we have used two hypotheses, considering varying material properties with the varying colors. We have used homogeneous material properties and heterogeneous material properties. For the heterogeneous properties, we have used the hypothesis of these properties varying with the airways, as deeper airways are typically softer and lower permeable than the main airways. However, the exact values for these material properties are still unknown. And for this reason, we propose to use an inverse problem formulation that tries to optimize these values for each patient. The idea is to minimize the distance between the surface of the deformed lung, here in blue, and the surface of the deflated lung as we observed it in the CBCT image, in green. The material properties that we allowed to vary in our inverse problem formulation were the rigidity of the solid structure, the permeability of the porous medium, the intrabronchial permeability that allows for fluid evacuation, the density of the porous medium, and finally, the position of the diaphragm. Each simulation takes up to 3 minutes. That translates in a time of between 3 and 4 hours per case. In order to evaluate our proposed approach, we performed 2 clinical studies. A preliminary study where we used a simplified context with lung deformation similar to VATS, and a retrospective clinical VATS study using the clinical data for VATS. For the preliminary study, we use low-dose CT data that comes from pneumothorax complication after transthoracic needle biopsy. We can observe from the images that there is a change of patient pose, as well as a pneumothorax, which is the deformation during VATS. The advantage of using these images is that we have access to the complete lung geometry before and after pneumothorax, and also that we have better image quality with respect to the cone beam CT images. The preliminary results using these images show that there is an overlap in the predicted lung position and the ground truth position of the nodule. And as for the quantitative results, we performed 3 deformation compensation strategies. First, rigid registration, then our proposed approach without taking into account the change of pose deformation, and finally, the complete registration framework that we proposed, both with homogeneous and heterogeneous material properties. These are the distributions of target registration error using this experimentation settings. We can first observe that it is only after taking into account both the change of pose and the pneumothorax deformation here in green that we obtain the best results. Also, we were able to reduce the initial average error about 30 millimeters to 10 millimeters, and specifically for the long nodule to 3.6 millimeters. And when evaluating the influence of heterogeneous material properties, we could observe that the dispersion of the errors was lower, but these differences were not found to be statistically significant. For this reason, we didn't take into account heterogeneous material properties for the experimentation with the CBCT images. I will present now the results for the CBCT images. For this experimentation, we used the clinical data that I already presented in the previous section with 5 PATS clinical cases. The qualitative results show again that there is an overlap between the nodule position that we predicted and the nodule position that we observed in the CBCT images. We were able to reproduce the lung deformation during pneumothorax with the proposed biomechanical model, as we can observe in the videos to the right. Regarding the errors at the level of the nodule, we were able to reduce errors more than 20 millimeters to up to 50 millimeters across clinical cases, to an average across clinical cases around 10 millimeters. As for the quantitative results, we performed the same 3 deformation compensation strategies: the rigid registration, the no change of pose, and the complete registration framework, that without taking into account the heterogeneous material properties. These are the distributions of target registration error for the rigid in red, no change of pose in blue, and the complete framework in green. We can observe with these experimentations, as we observed in a preliminary study, that is only after taking into account both the change of pose and the pneumothorax deformation in green, that we obtain the best target registration errors across clinical cases. We were able to reduce the initial error from a range of 21.9 to 37.9 millimeters to a range of 4.9 to 14.3 millimeters. To conclude this section, we have demonstrated the feasibility of a registration framework with 2 retrospective clinical studies, a preliminary study using low-dose CT data, where we obtained average target registration errors of 10 millimeters, and a retrospective VATS clinical study with 5 cases, where we obtained target registration errors around between 4.9 and 14.3 millimeters. We propose to decompose the deformation during VATS as a change of pose and pneumothorax deformations, and we show that it is only after taking into account these 2 deformations that we obtain the better results. And this is important because in the literature of the lung deformation during VATS, no study is currently taking into account the change of pose deformation. And we have performed some preliminary studies using heterogeneous material properties for the Young's modulus and the permeability of the porous medium, but we didn't find any statistically significant difference with respect to the homogeneous material properties. I will now conclude this presentation and present some perspectives. The objective of this thesis was to propose a methodology to account for lung deformation during VATS in order to estimate the intraoperative position of pulmonary nodules. We performed a characterization study of lung deformation during VATS, where we found very large lung deformation both for the change of pose and the pneumothorax, which highlights the importance of taking into account the change of pose patient's deformation that is currently not being taken into account in the literature. We propose to use a hybrid image-based, biomechanics-based framework for lung deformation compensation during VATS. This approach uses the image registration techniques and biomechanical modeling techniques in a complementary fashion, where for the biomechanical model, we have used a Proelastic model of the lung with allowance for air evacuation. And this is the first study taking into account both the change of pose and pneumothorax deformation for lung deformation compensation during VATS. We have demonstrated the feasibility of our proposed approach with 2 clinical studies with average target registration errors around 10 millimeters for both the studies. And in discussion with our partner thoracic surgeon, the clinical objective would be to go to an error of 5 millimeters. However, this is the first step towards computer-assisted nodal localization during VATS. This work opens many doors to perspectives. Regarding the image aspects, we may improve the quality of intensity-based image registration in the hybrid registration frameworks. And we have already performed some preliminary studies where we, instead of only taking into account the normalized cross-correlation between the images, we have also taken into account the cross-correlation between the image gradients. And using this approach, we were able to reduce the target registration errors considerably for some clinical cases. And in practical terms, including intensity gradients is allowing to improve the estimation of the sliding motion that we can observe in these examples. As for instance, this structure is present in the CVCT image, and it's not present in our current registration approach. Regarding the inverse problem, there is the current cost function uses the distance between the deformed surface of the lung and the extracted surface in the intraoperative CVCT image. And we are also trying to take into account the displacement of the diaphragm towards the apex. But since this movement of the diaphragm is mostly normal to the normals of the surface, the current cost function has problems in estimating the position of the diaphragm for some clinical cases. In order to take into account this deformation of the diaphragm, we plan in including internal lung structures in the computation of the cost function, such as key points that may be extracted using typical operators, such as SORF or SIFT operators. Also, an important aspect of an inverse problem is that we need to reduce the computation time for it to be compatible with clinical practice. And the idea would be that if we are able to reduce the simulation times to the order of seconds, then the inverse problem formulation will take in the order of minutes. And in order to do that, we plan to use model order reduction techniques that may improve the computation time significantly, and that deep learning approaches have already proven to be very useful. Regarding the modeling aspects, we would like to move towards a more realistic modeling. We have identified that both in change of pose and pneumothorax deformation, the lobe sliding is very significant, and we would like to take into account the different lobe deformation in future work. In addition, we will plan in studying the use of nonlinear elasticity models, specifically for the change of pose deformation estimation, since in this estimation we do not take into account the fluid domain, for which these are some preliminary results using these nonlinear elastic models. And we will also like to take into account heterogeneous material properties for the fluid evacuation term, as we observe local volume changes, and this may allow to represent atelectasis, which is a complex deformation pattern. And finally, regarding the clinical protocol, we would like to move, we would like to adapt our registration framework for using only an intraoperative CBCT image acquisition, since this will allow to simplify the clinical protocol and minimize the delivered dose to the patient. However, since we have shown that the change of pose estimation is very important, we will have to instead replace the acquisition of the image with a modeling step, for which some strategies may be studied, such as the statistical deformation model, if we have available data, or biomechanical models. This work has been presented in several international conferences and has been partially sent to review in an international journal. I would like to acknowledge the people and funding that have made this work possible, and I thank you very much for your attention.